All right, let's get started. Think of this as a virtual Viva session. We're going to tackle one of the trickiest topics in pediatric orthopedics, slipped capital femoral epiphysis, or SCFE. I'll present you with a case, and we'll walk through all the tough decisions you're going to have to make. Let's see how you do.
So picture this. Your patient's on the table. A 13-year-old comes in with hip and knee pain. You get this x-ray back, and it confirms it. It's a SCFE. Now, this is the most common hip problem we see in teenagers. But don't let that fool you. The calls you make in the next few hours, well, they're going to define this kid's mobility, their risk of arthritis, and their quality of life for the next half-century. No pressure, right?
Here's our game plan. We'll kick things off with the absolute first thing you have to assess. Then we'll dive right into the controversies, how to fix it, how to handle the really bad ones, and of course, the big debate about what to do with the other hip. And at the end, I'll give you my final take. Let's get into it.
Okay, let's dive right in. You've made the diagnosis. It's an SCFE. Now, before you even start thinking about what size screw to use or your surgical approach, there's one single crucial thing you have to figure out first.
So I'm asking you, doctor, what is it? What's the number one factor that's going to guide your entire management plan and honestly dictate this patient's whole prognosis?
The answer is stability. And we define it using Loader's criteria, which is just beautifully simple. It has absolutely nothing to do with the x-ray. It's all about the patient sitting right in front of you. Can they or can they not put weight on that leg? That's it. It is a simple yes or no question, and it changes everything.
So why is that one simple question so incredibly important? It all comes down to this number, 47%. In his landmark study, Loader found that almost half, nearly half, of all patients with unstable slips went on to develop avascular necrosis, the death of the femoral head. And for the stable slips, that rate was zero. Zero! I mean, this is one of the most powerful predictors we have in our entire field. It tells you the risk of the absolute worst complication before you even pick up a scalpel.
And that leads us to the next big question. Timing. Is an unstable SCFE a true surgical emergency? We'll take a look at this timeline. The data kind of hints at this unsafe window for surgery, somewhere between 24 hours and 7 days where the AVN rate seems to jump. But, and this is really important, this finding wasn't statistically significant. So while our gut screams to get the patient to the OR immediately, the hard evidence for a strict 24-hour rule, it just isn't quite there yet. All right, let's switch gears. We're going to focus now on what you'll see most of the time, the stable, mild to moderate slip. In these cases, the risk of AVN is super low, but you face a totally different kind of problem. It's a trade-off, really, between immediate safety and long-term function.
So this is your fundamental choice. On one hand, you've got in situ fixation, or ISF. It's safe, it's reliable, and the AVN risk is tiny. You just put a screw across the growth plate to stop any more slipping. The catch? You're essentially locking that deformity in place forever. On the other hand, you could go for an anatomic reduction, like a modified Dunn procedure, and make the hip look perfectly normal again. This might prevent impingement problems down the line, but it is a much bigger, much harder operation with a higher risk to the blood supply. So let's look at the long-term impact of that safe choice. When you do an in situ fixation, you're leaving that bony bump at the junction of the head and neck. And a recent study found that a staggering 78% of these patients had clear signs of femoral acetabular impingement, or FAI, on their follow-up x-rays. That is a massive number.
But, and this is the crucial part of the whole debate, of that big group with worrisome x-rays, only about 28%, less than a third, actually had any clinical symptoms. The majority felt totally fine. And that's the dilemma, right? Do you put every single patient through a bigger, riskier operation just to fix something on an x-ray that might never actually bother them? This is exactly why in situ fixation is still the standard of care for most of these mild and moderate slips.
Okay, let's move on to the really tough cases. We're talking about the severe, often unstable slip. Here, the deformity is huge, the risk of AVN is sky high, and your choice of surgery carries enormous weight.
This table sums up the best data we have from a big meta-analysis. Just look at the numbers for unstable slips. Pinning it in place gives you an AVN rate around 18.5%. Trying a closed reduction, that bumps the risk to 23%. And the super complex modified Dunn, it's sitting right around 20%. The main point here is that they're all kind of in the same ballpark, which is what makes this decision so incredibly hard.
So you're probably wondering, if the AVN rates are all so similar, why would anyone choose the much harder modified done? Well, this quote really gets to the heart of it. It comes down to one word: control. The whole theory is that by surgically dislocating the hip, you can actually see and protect those delicate blood vessels while you realign the head. It turns a blind maneuver into a very precise open procedure. But let me be crystal clear. This is expert-level stuff. The outcome is highly, highly dependent on the skill of the surgeon holding the scalpel.
Excellent. You've stabilized the bad hip. But the consult's not over. Your last and maybe the most controversial decision is what to do about the other side, the hip that's currently perfectly fine. And this is the prophylactic pinning dilemma. The argument for it is pretty compelling. We know that up to 65% of these kids might eventually slip on the other side. But the argument against it is just as strong. You're going to be doing an unnecessary operation on about half of them. So what's the right call? There isn't one. This has to be a shared decision you make after a really good long talk with the family about all the risks. And to have that conversation properly, you have to be brutally honest about the downsides. So let me ask you, is putting a screw into a perfectly normal, healthy hip a totally harmless, risk-free thing to do? The answer is a hard no, and these images show you exactly why. On the left, a routine prophylactic pinning. Looks fine. On the right, that's the same hip after that kid had a simple fall. They sustained a subtrochanteric femur fracture right through the stress riser that was created by that supposedly safe screw. Now, it's a rare complication for sure, but it is absolutely devastating. You have to make sure the family understands that preventative surgery is never, ever risk-free.
All right, doctor, you have navigated some serious controversies here. Stability, fixation, the other hip. Let's try to boil all of this down into a clear, actionable pathway that you can actually take with you.
Here is your framework. Step 1, always assess stability with Loder's criteria. It is the most important piece of information you will get. Step 2, for those stable mild to moderate slips, the evidence really supports in situ fixation. Your job is to talk to the family about the high chance of seeing FAI on an X-ray, while also reassuring them that actual symptoms are way less common. Step 3, for the severe and unstable slips, you have to think about an anatomic reduction like the modified done, but you have to be honest with yourself and the patient about how demanding that surgery is. And finally, Step 4, the other hip is not an automatic pin. It requires a detailed one-on-one discussion about risks and benefits.
So I'll just leave you with this. When you treat these kids, remember our goal is not just to get a perfect-looking X-ray. The real goal, the only goal, is a painless, mobile, functional hip that is going to serve them for the rest of their life. How you navigate these controversies is what makes that a reality. Good work today.